we'll now talk a little bit about the symptoms. How does a mental health practitioner make a diagnosis, and what does that entail? So some of you may be familiar with what's called the DSM, the Diagnostic and Statistical Manual for Mental Disorders. This is the book, this is the Bible, if you will, of diagnosis in psychiatry, where all of the major psychiatric disorders are documented and there's specific criteria to make the diagnosis. And this was the 5th version of this manual. This came out in 2013. Since then, there have been some updated what's called text revisions, but essentially it's the same criteria for a diagnosis of major depressive disorder. So to meet the criteria for MDD, you have to have 5 or more specific symptoms over a 2-week period. And these symptoms would be more days than not. It would be chronic, they would be distressing, they would be impacting quality of life, function, and other aspects. So the 2 cardinal symptoms of major depressive episode is depressed mood. So that could be a low mood. There's any number of ways to phrase that. For some, they may say, I'm blue. Some may say, I'm sad. Some may say, I'm despondent, or I've been tearful a lot, or some may call themselves melancholy. There's any number of ways of describing depressed mood, but it's this distinct quality of mood that is differ from a patient's normal mood. And anhedonia is something we'll get into a little bit more in detail. That's also considered one of the 2 cardinal symptoms of depression. And so anhedonia is the loss of interest, or the absence of interest and motivation, the inability to experience pleasure. And it's classically described by patients where things that they used to do they used to enjoy, like reading books or going for walks or attending plays or watching movies or socializing with friends, they're not looking forward to those activities anymore. They're not motivated to do these things anymore. So it's a clear loss of interest, loss of motivation for things that they otherwise would have found pleasurable. And that's considered such a cardinal symptom of depression that you can actually have a situation diagnostically where a patient denies being sad or having a low mood or depressed mood, but could still meet the diagnosis for a major depressive episode because they have anhedonia. So they don't care, they're not motivated, but they don't really say that they're sad. They just are anhedonic. Then you see some of these other symptoms as you go down the list here. There are generally, most patients with depressions have some kind of disturbance with sleep. For some patients, it's insomnia, so meaning they have a difficult time going to sleep, or in the middle of the night, they have awakenings, or at the end of the night, they wake up earlier than they normally would. That's so-called early morning awakening. So when their usual wake-up time is 6 a.m., they may wake up at 4 a.m. and unable to get back to sleep. So there's insomnia can be found in all phases of the sleep cycle, beginning, middle, and end of the night. Now, there are some patients who sleep too much. So that's called hypersomnia. So when they're well, they may sleep 8 hours. When they're depressed, they may sleep 12 hours. They may sleep 16 hours. They may sleep most of the day and then take naps. And so that's what's called a reversed neurovegetative symptom, So they're sleeping too much instead of sleeping too little. And then we'll get into appetite, but they may be eating too much as opposed to eating too little. So another symptom is fatigue or loss of energy, and that may a very common symptom where, and this could be tied into the lack of sleep or the poor quality of sleep. If you're not sleeping well, it would make sense that you're fatigued for a good part of the day. You just don't have energy to do things. And the lack of energy, it could be this vicious cycle. You didn't sleep well, you were then have low energy, you're fatigued for during the day. So then it impacts your motivation to do things because you're so fatigued and loss of energy. So there is a relationship across these symptoms. Weight loss or weight gain. So patients with certain forms of depression can lose 30 pounds over a several month period where food loses interest. I mean, you lose interest in food. Food takes a tasteless quality. Friends and family members have to force the patient to eat because otherwise they would just go the whole day without eating much of anything. So it could lead to weight loss. Some patients do eat excessively and have weight gain during these episodes. Those can be associated with the hypersomnia. So you have these so-called reversed neurovegetative symptoms leading to weight gain. Psychomotor agitation or retardation. So psychomotor retardation is a slowing. So there could be slowing of speech, there could be slowing of movements. So you see a patient with severe psychomotor retardation, they're almost frozen. They they have very little sort of movement. They're just speaking very slow. Their 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 motor system has been shut down. And there's patients on the opposite end of that where they're agitated, they're fidgeting around, there's look like they're sped up, and they have this agitated feel about them. It's could be mixed with anxiety, and it could be difficult for them to describe. But an agitated depression is extremely uncomfortable. They're what's sometimes referred to as tired but wired. So some people, when they have too much coffee or caffeine, can get quite agitated and wired. And so it's this excessive motor activity. They could be fidgeting around, they could be shaking their legs. And it gets to some of the important subgroups of major depression, which includes patients with a major depressive disorder with mixed features. And we'll get into that in a subsequent slide, but about 20 to 30% of patients have aspects of both depression and bipolar disorder. So bipolar disorder is another mood disorder marked by highs and lows. And the highs can be extremely pleasurable, but in an extreme form can become psychotic or delusional and often ends up in hospitalization with an extreme manic episode where you go several nights without much sleep. You may be speaking really fast, thoughts are racing, there's a lot of motor activity, there's a ton of energy, feel sped up. And there are forms of mania that's not so severe called hypomania, and when that is intermixed with depression, depressive episodes, that gives you a diagnosis in some patients of a bipolar 1 or 2. But patients with major depressive disorder, so-called unipolar depression, some of them can also have at the same time these up symptoms or hypomanic manic type symptoms, and that's called a mixed specifier. And then there's some of the psychological symptoms: worthlessness, excessive inappropriate guilt. Things are my fault. I am to blame for a lot of things. Feeling low self-esteem, that's often marked as one of the symptoms. These feelings of worthlessness, I'm no good, things like that. Diminished ability to concentrate, that ties in closely with many of these symptoms. As you can imagine, if you're fatigued, if you didn't sleep well, if you're feeling bad about things, it can be quite difficult to focus on conversations. It could manifest in the classroom as inability to think or to remember things from lectures or from your readings. And a lot of people come into the office, what we see, the complaint is, I have ADD, I have attention deficit disorder, I can't focus in class, I can't concentrate on what I'm doing. I can't, I have ADD, I need a psychostimulant or something along those lines. Now, ADD is certainly found in the college population and in others, teenagers and adults, and it's a well-known diagnosis. But one of the first things we want to consider when a patient says they can't concentrate, we want to explore further. Is this concentration issue part of a depressive syndrome? And in fact, is a better diagnosis depression or major depressive disorder or some variant of depression? And so the isolated symptom of concentration deficit should trigger a whole host of other inquiries. And then we did mention that depression can be associated with suicide at completion, suicide attempts, but most commonly what we call suicidal ideation, just the thoughts of death, which can range from anything that I would be better off dead, or I wish I could go to bed and not wake up, to having thoughts, well, it would be nice if I could just take some pills and go to sleep and not wake up, to thoughts that I want to buy a gun and keep it and possibly do something to hurt myself, to explicit plans that the patient has written a suicide note with a specific plan to do something. And unfortunately, there are proportions of patients with both bipolar disorder and major depression who do go on to complete suicide.